Good afternoon. I want to welcome you all to this afternoon's lecture with Professor James Robinson from the School of Public Health at UC Berkeley, who will be speaking on the Affordable Care Act, what health professionals and consumers need to know. My name is Stan Weisner. I run the Behavioral Health Sciences programs at UC Berkeley Extension. We have courses for professionals in social work, public health, addictions counseling, social services. And this material that you probably picked up at the door lays out all the various course content areas that we offer for people mainly in the mental health area and the allied health professions. We offer programs in mood and anxiety disorders, eating weight disorders, child and aging programs. We have a trauma neuropsych series for clinicians. And they meet the needs of practicing clinicians in the Bay Area primarily. This year we also launched a new program in health advocacy to train and help professionalize the growing number of patient navigators who will be increasingly called upon to assist patients and their families, many with growing numbers of frail elderly parents and grandparents, help them negotiate an increasingly complex and daunting dynamic healthcare system in this country. So I needn't tell this audience how important this kind of knowledge and skill base is as each of you continue to expand and improve your own clinical research, interventions, and policy skills in a variety of healthcare settings. Our upcoming programs in the Health Advocacy Series include one on intergenerationally working with families, pediatric advocacy, an overview of insurance options, increasingly important area of interest, and a course on levels of care. An outstanding workshop this in March on the 9th in San Francisco here with Jeff Belcora, who I met a couple years ago. He's the director of a position at UCSF called Decision. He's the director of Decision Services. I said to him, what is that? It's to help, in this case, women with breast cancer decisions as they pursue their treatment regimes. And he has a one-day workshop on helping people make informed choices. In addition to our regular offerings, which I just briefly described in my area, we offer, with Dean's Office support, a series of free lectures as a public service each term. And I have the pleasure of introducing this afternoon's speaker, who will be addressing one of the most significant policy advances in a generation, really, in this country on healthcare reform. Jamie Robinson is the Leonard Shepard Professor of Health Economics and Director of the Berkeley Center for Health Technology at UC Berkeley and the Integrated Healthcare Association, and contributing editor for the Health Affairs Journal. At Berkeley, Professor Robinson teaches health policy and economics, has published over 100 papers in peer-reviewed scientific and policy journals, published a book on the corporate practice of medicine, as well as a prescient chapter some decade ago on restructuring Medicare, the role of public and private purchasing alliances, in a book called Medicare, Preparing for the Challenges of the 21st Century, which in fact we now are living through. He's also currently working on a book, I understand, entitled Purchasing Innovation in Healthcare, all very topical subject matter. So without further ado, I want to introduce Professor James Robinson and thank him very much for coming. He will be speaking for approximately 45 minutes to an hour and taking questions as we proceed. Thank you very much for coming. Good afternoon.
So a couple of words about myself. I am a professor at Berkeley, been there for a very long time. I'm now part of the problem. And I do teach the economics of healthcare. I focus on payment methods, insurance coverage, consumer cost sharing for physician and hospital services, health insurance. And over the past 5, 6, 7 years, I focused a lot on medical technology, high-cost drugs and devices, things of that nature, how that's all going to get paid for. And obviously working in the healthcare field is fabulously interesting. It's always in the newspaper. Everybody's got a strong opinion on the topic, usually a strong different opinion on the topic. And that's good, and it really touches all of us professionally, and it also touches all of us personally. And so it's not just an arm's length. It's not happening far away. It's happening right here. And of course, the Affordable Care Act is a very big piece of legislation that has been the whipping boy for every form of anxiety, complaint, et cetera, about the system, about American politics, about the government, about the market. And it adds, it's a wonderful thing in certain ways. In other ways, it adds to the incredible complexity of the healthcare system. I've come to decide that the greatest single problem facing the American healthcare system is it's too complicated. We don't understand it. I'm an expert. I do this all the time. I don't understand it. I keep bumping into parts of healthcare that are huge, and I'd never heard of them before. And so I'm going to lead you through the Affordable Care Act at a sort of a middle ground level. I'm assuming that some of you are experts on this already. Some of you are concerned citizens sort of starting off, and others of you are sort of in the middle. And but actually, I just want to a little show of hands. How many of you work in healthcare? Okay, so a lot of people. Right, that's what I assume. And so, to some extent, people work in healthcare. Well, how's this going to affect me and my job? And I will be right up front in saying that I can answer some of those questions, and there's just a lot of those versions of that question that I cannot answer. And because it gets very techy very quick. Like yesterday, this was the question I was posed. How will the Affordable Care Act handle the out-of-pocket maximum for enrollees in CalPERS's self-insured PPO plan who are getting orthopedic joint replacement, whether they are ERISA covered or under the Department of Managed Healthcare or under the Department of Insurance? I actually can answer that question. But your questions, oh no. But anyway, so the way I like to do this is I have got my slides and I will be going through those. But I also like to have questions as we go along, and I will follow those up and be very happy to do that, and to the extent I can. I've got a clicker issue here. Where's my clicker? If I'm going to advance this thing. Okay. And I'm also, because the screen is over there, my screen's over there, and I'm here, I'm going to be kind of looking at this just to make sure I know where I am. But basically what I want to do is I want to talk a little bit, obviously we were just coming out of the election and out of this, the new era of what part of the ACA is actually going to be implemented. Well, first of all, what does the ACA say as written, and then what's it going to actually be implemented in the world in which we are, the political world and the economic world in which we're at. I am not going to start with what does the ACA do, except in the very broadest terms, because the ACA does a bazillion things. But a lot of what we're going to really care about is what's actually going to be implemented in the political environment and the economic environment that we're in. Just in terms of what does the ACA, what are the goals of the ACA, what's it really do? The ACA has two basic goals. The first, it's like an 80-20. 80% of the ACA is seeking to increase the access of people to health insurance and thereby to health care. So its main target has been the 50 million Americans who lack health insurance. And if it were fully implemented, which it will not be, but if it were fully implemented, approximately 30 million of those people would gain insurance coverage under the provisions of the ACA. That leaves about 15 to 20 million out. Those people are undocumented, illegal aliens and various kinds of that nature who are not covered by the ACA. And so there will continue to be an uninsured population even after full implementation, and therefore there will still be a need for safety net, public hospitals, clinics, all that stuff. But as far as the coverage, about half of the people who would gain coverage will gain it through expansions of state Medicaid programs, Medi-Cal in California. If that happens, and we'll be talking about that, will happen very unevenly. Some states, like California, are embracing Medicaid expansion. Other states are refusing any Medicaid expansion because Medicaid is jointly funded by the federal government and by the states. And so the states have a strong interest in this from a fiscal thing. But about half of it would go through Medicaid, and the other half would be people who would gain commercial health insurance, primarily on a subsidized basis, primarily through these famous health insurance exchanges, which is a way of getting access to insurance without going through an employer. These are people who don't have employment-based insurance. And it would also come for them with subsidies, depending on their income. The lower income, the poorer they are, if you will, the more of a subsidy they get. If they're really poor, they'll be on Medicaid. But it's really the people above that. Most of the uninsured people in America are not poor. They are what we call the working poor. They are a level above Medicaid, but they work in jobs so they don't make too much to be on Medicaid, but they don't earn enough to have employment-based health insurance. And so they would have subsidized insurance at least for the first 3 years. And of course, the dilemma of the ACA is that it's all about, it's a federal legislation that uses federal money to expand coverage, but only has federal money for 3 years. Okay? And after that, it's supposed to be, I don't know, the Medicaid plan starts going back to the states, and as you know, in the great state of California, we are great, we are smart, we are the most innovative part of the globe, and we are virtually bankrupt. Okay, so that's kind of us. So you get to pick Medicaid, the University of California, or the prison system. You can have 2 of the 3. Which ones you want? And then at on these exchanges, the federal the subsidies are very important. And of course, the subsidies is federal dollars, and it really depends on something called the federal deficit. Okay, federal deficit is the fact that China owns a big slice of the United States, and which has been really very generous of the Chinese people to buy U.S. Treasury bonds at virtually 0% interest and help us pay for Medicare. That's who's paying for Medicare is the Chinese right now, and that's just great until if they ever want their money back. Okay, and my proposal is we should just, at some point, we just have to sort of come clean with the Chinese. We don't have the money to pay them back, so we'll like give them, I don't know, Hawaii. You know, and then we'll just, okay, they give us all our bonds back, they get Hawaii, we're good. All right? But anyway, so that's the ACA in a nutshell. All right? So the question is, as written, the question is, what part of all this thing is actually going to be implemented given the politics? It's just turned out to be an incredibly political thing. And to show my personal biases, just in case you haven't, I support the ACA. I think that the problems that it addresses of coverage, and by the way, the other second problem, that was his main was coverage, and then the second was cost control, are both very serious issues. I think that it was designed by the Obama administration to try to achieve the social goals of universal coverage or quasi-universal coverage and some cost moderation with the least amount of change in the system as a whole, because most Americans say the U.S. healthcare system is terrible, but I like my healthcare. And so the president has to say something like this, which is what he says. We're going to fundamentally transform this healthcare system, but if you like what you've got, you can keep it. That, of course, is impossible. All right? That's, excuse me? Impossible. We cannot fundamentally transform the healthcare system and allow 75% of the people to keep doing whatever they've been doing. It's just not possible. It's going to affect everybody. Everybody's going to have different kinds of care over time, and they will be paying different amounts. That's just all there is to it. Now, I get to say that because I am a full professor, step 7 off scale with tenure and an endowed chair. I'm not running for office. Okay? You can't vote me out, so I can tell you, you're going to pay more and you're going to get less, because that's the way the system is. That's where healthcare is going, because right now, the Chinese are paying for it. Okay, and it's whenever we stop doing that, then we all have to pay more and accept less, or we give up something else that we really like, like kindergartens and prisons and whatever we like, whatever else we like. Okay, all right, so let's go. We're going to talk about the election results, the fiscal cliff, by which I mean, sort of the economy, and then some implementation issues, and then going forward. Okay. All right, here's the map of the election. As you know, this actually is the Democrats did very nicely and much better on the electoral vote than on the popular vote. As you know, the popular vote is basically 50-50. America is a very divided country politically. That's the punchline, and it will continue to be. The Senate make up the big victory, of course, for the Democrats in that they didn't lose control of the Senate. They now have a majority, a slight majority, but they do not have any kind of filibuster-proof majority in the Senate. There's no question about that. Nothing's going to go through the Senate that really, really, really rattles the Republicans. They're going to have to be somewhat bipartisan. And even worse, from the Democratic point of view, of course, is the obvious fact that the House is still controlled by the Republicans. Now, the Republicans obviously have greater problems than the Democrats do. They have to find their vision. They have to re-engineer themselves. And they thought that this was going to be a landslide in their favor. It was not. They thought that the Obamacare was going to bring down Obama. Okay? It is the historical pattern. By the way, every approximately 20 to 30 years, there's a Democratic president in the United States who embraces the principle of universal health insurance and really puts a serious legislative effort and bill forward. The Democrats put a bill forward on that, and 2 years later, there's a Republican landslide. That's like one of the continuities in American politics. Okay, it certainly happened in this case. Obama came in with a big majority 4 years ago, spent a lot of his political capital on health care. 2 years later, Republican landslide. All right, the Republicans. And everyone was believing that the momentum of that would continue. Certainly the Republicans were believing that, and they were wrong on that. And so one of the best things that happened in the election, if you're a Democrat, is that Obamacare didn't bring Mitt Romney into the White House. Okay, thank you, Obamacare, for keeping your head down during the election. Okay, people did not vote based on Obamacare. All right. The interesting thing is going to be what's happening at the state level. I find this is actually one of the most interesting things. This is what percentage of the 50 states have veto-proof majority in one party, by which they mean that the House, the state Senate, and the governor are all of the same party. And as you know, the polarization of America is growing, and so that number is growing. It is now at, I believe, 37 states that have that, most of which are Republican states. And so I think we've got the map right here. The supermajorities here at the top, the red being obviously the Republican states, which they get to decide, and the Democrats realistically can't stop them on issues like state-level health policy. And of course, the blue states, including the great state of California, are all in the hands of the Democrats. All right. So what you're going to see is if you like that little political science thing, the states, the laboratories of democracy, well, you're going to be seeing a bunch of that because they're going to be able to actually pass legislation. This is a little bit new for the American people. American people like divided government because divided government doesn't get much accomplished, and that's what we like. All right. We are people culturally descended from people who fled other countries that had strong governments, and we apparently don't like strong government because strong and efficient government is tyrannical government in the American psyche. Psyche. And most of the people who came here were descended from people who were fleeing either King George or the Tsar or some other despot or something like that, and they just love having Democrats in one house and Republicans in the other. But now we'll actually see some legislation. And the interesting part is even though the Republicans took a terrible beating in the national election, they control, I believe, 24 states. Okay, so they are all united about one thing, which is that Obamacare and the ACA is the making, the doings of the devil. All right, that's a rallying cry, and they want to stop it, particularly the Medicaid expansion, and the health insurance exchanges, and then anything else. Okay, and they've got 24 states to do that with. These states happen to be the states which have the most uninsured people, of course. One of the great ironies is that Obamacare it's a big effort to raise taxes in high-income liberal states like California and spend those taxes in low-income Republican states like Arkansas and Tennessee and Wyoming and Mississippi. And the people in Mississippi apparently don't want it. That's going to be one of those big dilemmas when we get to the Medicaid thing is that, you mean you don't want our money? I'm actually to the point where I'm like, you don't want our money? You don't have to take it. I'm kind of like, I'm there. It's like, Anyway, so let's keep going. Obamacare. the public's view on Obamacare continues to be extremely split, right down the middle. It fluctuates a little bit, but basically half the people like it and half the people don't like it. That is not what, of course, President Obama and the Democrats were anticipating. They thought that this was going to be a runaway winner of a topic. What do you mean? Universal coverage? America, everybody, you ask people in America, do you believe in universal health insurance? And everybody says yes. And then you ask them, would you be willing to pay more for universal health insurance? And everybody says yes. And then you ask them, how much more would you be willing to pay for universal health insurance? And they say, $7.50. Right? And would you like the government to do that? No. Okay, so that's our dilemma. We use bumper stickers, keep the government's hands off of Medicare. Okay? That's a classic Americanism. Right? And off of my guns. Right? Okay, so it has not been a great winner, and it's still, and I think that the hope of the proponents is that as it sort of settles in, people will become used to it, and then they'll decide that they like it. And repealing portions of it will become less and less feasible. The most obvious was the very first thing that they implemented was a few very popular things like requiring employer health and basic health insurance to cover children up to the age of 26. Well, there's a bunch of people out there who have kids up in college who are now covered and who are like, wait a minute, I like this. I like this. And they also have limits on underwriting by which insurers can have, in the past, they won't sell insurance to people who have pre-existing health conditions. Now they cannot do underwriting on children, and in the next year they won't be able to do it on adults either. Once people get used to that, they like it. They like it. So there's going to be a variety of things. On the other hand, also the things that the Americans don't like, apparently, is taxes, except for on rich people. Rich people, by the way, the definition of a rich person is somebody who earns more money than me. That's like the definition. Okay? So the most likely scenario is that people want all these new health, the rights, the benefits, and they want lower taxes. That's kind of like, In fact, that sort of sums up health policy right there. And that's the dilemma for the wonks have to kind of try to make that work. The politicians, they're going to stare you right in the eye and would say, we're going to give you all these new benefits and we're going to cut your taxes. And the federal budget deficit is going to go away. You know what I mean? And then, boom, vote for me. And then they turn, and it's like all the policy wonks have to kind of make that work. All right. So and anyway, no change, and whatever. Okay, now, fiscal cliff and just the paying for this. Now, we got past the fiscal cliff in the narrow sense, but we haven't gotten past it at all in the larger sense. All that's happened is that what happened with the recent agreement between President Obama and the Republicans was that they did not lower taxes on the very wealthy, but they lowered taxes on everybody else. In other words, the Bush tax cuts were made permanent. Okay? The way to deal with massive budget deficits as far as the eye can see is to make permanent Republican tax cuts. Oh, okay. All right. That was the Democratic win. All right, you go, oh, okay. Okay, I got it. All right. So now we're looking at deficits, and Obamacare contributes to it, but there's a lot of other things that contribute to the deficit as far as the eye can see. And no one is in the mood for tax increase. The tax revenues are going to go up as the economy takes off. And what we all hope is that the economy will improve significantly, that more people working, earning more, therefore paying more taxes just kind of in the normal course of things without thinking about it too much. And then spending less unemployment benefits having to go out the door, less welfare, less all of that stuff. That there's no question macroeconomic recovery and labor market recovery will help on the deficit. But nevertheless, the deficit's there, it's growing, and it's mostly driven, as you look forward over time, in increases in healthcare costs, mostly Medicare. The federal budget deficit is really a Medicare issue. Because there's an aging population, particularly in about the next 10 years, the baby boom population goes on to Medicare. And then, of course, as people age, they use more health care. And even more importantly, the incredible creativity of the medical industrial complex is developing always new tests, treatments, drugs, devices, procedures, etc., for people with health problems and preventive issues, things. And all of that costs money. And so the cost per beneficiary, the number of beneficiaries are going to rise, and the cost per beneficiary is going to rise very dramatically. And so that Social Security is not going to be an issue. Social Security is driven by the number of beneficiaries. That's going to rise gently, but that's not a problem. It's the cost per beneficiary in Medicare, which is the big issue. And on the state level, it's Medicaid. And on the private sector level, it's the commercial health insurance on the burden on the employer. And it's really that. And we have not made any progress on that. And in the recent agreement there between the President and Congress, there was no movement on that. There was nothing on the expenditure control side. It was all an agreement on the revenue increasing side. Okay. So it was definitely good to get us past the fiscal cliff, but now we're looking at the debt ceiling. And behind the debt ceiling, there's just simply deadline, which is in March. There's going to be a series of very disagreeable funding and issues in the public sector. There's simply no question about it. And the two parties have to decide how much they want to be bipartisan and solve this, and how much they want to blame each other. The Democrats blame the Republicans for trying to, cut taxes for the rich and take away Medicare, and the Republicans blame the Democrats for wasteful spending, and it's, all of which is true. All right. Okay. For health care, the cuts that this was, if we had gone over the cliff, which we didn't, but we didn't solve any of the reasons that would have pushed us over the cliff. You just see these are the things that would hit the different parts of healthcare, and this is CMS, means Medicare. Basically, a big part of Obamacare was to, remember, what is Obamacare? Where's the money go? The money goes to the states to expand Medicaid and subsidies for people getting health insurance through the exchanges. That's like that's where the money's going. Where's the money coming from in Obamacare? There's a variety of taxes. There's some new taxes on drugs, on the medical device companies, on insurance companies. Every bad guy has to pay more. But the big money is coming from squeezing out payments to providers, that means hospitals, by Medicare. And the question is, that's even a great implementation question right there. Is Congress going to really squeeze the hospitals hard? Okay. Now, let's just ask, can Congress squeeze doctors hard? Well, if you follow healthcare, which some of you do very closely, you know that over the past, I think it's about 10 years now, we have the sustainable growth formula, which basically says that Medicare should cut the fees under Part B for the physicians because the total volume of physician services has risen faster than expected, and so we're going to cut the price per service to keep that somewhat in line. And every year, Congress punts on that and says, well, no, we won't actually implement that. We'll just kick it to the next year. And then the amount that they have to change it grows every year. The amount that they have to cut it to. It's now, if they actually went forward with the formula, they would have to cut physician fees by about 30%. Physicians would simply say, a good chunk of them would say, I don't think I'm going to be seeing a lot of Medicare patients right now. Okay. Or they can say, we'll just get rid of that formula. Congress can just write a new law. But if it writes a new law getting rid of the sustainable growth formula, it has to run that through the Congressional Budget Office and all those people that do an estimate of what's that going to do to the deficit. I think it's $300 billion or something on top of the existing deficit. They can just kick the can down the road. Right? So if they can't cut physician fees, you think they're going to cut hospital fees? DRG conversion factor. Possible. It's been done before. That was called the Balanced Budget Act. Those of you that have been in the healthcare business for a while, you remember that. On the other hand, it should be remembered that hospitals are the largest private employer in most cities in America. They're very labor intensive. A lot of people work in hospitals. A lot of those people vote. Okay? A lot of people are on, a lot of hospitals are not for profit, and they have board members who typically are prominent members of the local community who are big boosters of that. And just generally, everybody loves their local hospital. I mean, not in San Francisco, but, elsewhere, people really love their hospital. And so if that hospital goes into danger zone, it's a problem for the politicians. So, but anyway, that's where the big dollars are supposed to come. And the hospital CEOs these days, if you listen to them, and I spend a lot of time with them, their mantra, one of their mantras today is we need to break even on Medicare. They've been raising prices to the private insurers to make up for what they view as underpayments by Medicare. And the problem with that is that they've been so successful at that, raising prices to the private insurers, that the private insurance is extremely expensive, and that's what's leading to the erosion of insurance coverage as more and more employers and individuals say, I won't buy that. Those people then go on uninsured, and then under Obamacare, they bump down to either Medicaid or to these exchange products, which are going to be very thin, so-called bronze products, which are not going to pay hospitals very much at all. And so the hospitals are, the pricing strategy is shrinking the good payers and expanding the bad payers from the point of view of hospital revenue. And they know that. And they're worried about that. And so they're trying to keep their costs, moderate cost growth, which is very hard. Hospital, let's be sympathetic to hospitals. I'm very sympathetic to hospitals. They've got very labor intensive, and they're competing for labor. It's been a recession, but we're coming out of that. New technology, they want to have the stuff. They are supposed to provide care for uninsured. They have to, charity care, depending on where the hospital is a big deal. Small deal elsewhere. And facilities and regulations. Everybody likes to regulate the hospitals. It's just a seismic retrofit, staffing ratios, everything. So they've paid for that by charging Aetna and WellPoint and people like that a lot. And now they want to break even on Medicare. They say we've got to reduce our cost structure, but Medicare, according to this, is going to go down. So they're not even at Medicare level, and they're supposed to even go down. That's going to be like good, best wishes for the CEOs and all of their people to manage that, because the dilemma is that this may change, but I think that right now the American public is still under the belief that we can have our healthcare system the way it's been. We can expand it to the people who've had access problems, and we don't have to pay more unless we're in the 1%. I think that people kind of think that, and that, my friends, is wrong. That is not wrong. That is not going to work. It's just not. The math just doesn't pencil at all. So, but the public isn't there. The public isn't there. They're not into this, and it's understandable because the politicians tell them, both on the left and on the right, you can have health care. The only problem with health care is, the bad guys. If you're on the left, the bad guys are the corporate profits and that kind of stuff. And if you're on the right, it's the overregulation and mandates and government, basically. Okay. All right. So this was fiscal cliff. If we'd gone off the fiscal cliff, big bad news for the economy because, and we didn't, which was very good. But once again, what fiscal cliff is driven by is the deficit, and the deficit has been increased rather than decreased by the solution to the fiscal cliff. Okay, so it's a very classic kick a can down the road. Okay, all right. So now we're going to move to a little bit more of the nitty-gritty on the implementation, health insurance exchanges, and Medicaid. But I'm going to pause right there and say, any questions? Yes, ma'am.
Do you think that I got the impression that a lot of it was going to be funded, and everybody knew that by the zillions of people who had no access would be coming into the system and paying something, and that would be a lot of money that would go into that new program.
Well, let's go over that. The new people, the new 30 million people that are going to be coming into the insurance system, half of them are on Medicaid. They pay nothing. So let's forget about the first 15 million of these people. The next 15 million are going to be coming in, and they're going to come in under one condition, that they're subsidized. There is like, anybody that wants to buy unsubsidized health insurance can do so right now. They don't need to wait for Obamacare. We'll sell you insurance right now. So people don't want to buy insurance. They want to, with their money, they want to buy insurance with the government's money. Okay? Now, how much of the government's money? Well, the lower income you are, the more, and so there's going to be people that are going to come in at like 80% subsidy and stuff like that, and that's going to be really good for them. It's going to be a total bargain. We don't know how many of them will actually take it up. Now, under the law, another aspect of Obamacare, it's carrots and sticks. The carrots is the subsidies. The sticks is the mandate that you actually have to buy insurance. And if you don't, what if you don't? They take your firstborn child. No, they don't. They give you a small fine. Okay. First of all, they've got to fine you to get you. But even if you really are like a if you're like one of my students are all 25 years old and outrageously healthy. You know, they're doing the triathlons. I know that because they don't come to class, so you know. Most of them have no real health problems. And right up until recently, they've been covered by health insurance from their parents or somebody else, and that's fine. But when they have to actually pay for it themselves, it's going to be a really terrible deal for them because your typical young person goes to the doctor a couple times a year. What's a doctor visit cost? $100? Okay, so they're paying, and they may have a few drugs. So $200, $300, $500,000 a year in healthcare costs. Okay, what's health insurance cost? What's health insurance cost?
Cost me $10,000 a year.
Well, there you go. So which would you rather pay, $1,000 or $10,000? They're all going to go like, oh, I think $1,000. Then Obamacare will say, oh, if you don't buy it for $10,000, we're going to give you a fine. What's that fine going to be? Oh, $300. Oh, okay. And if you really get sick, you could always go to San Francisco General. Right? Or you can wait, and you say, oh, yeah, now I'm thinking of maybe of having a baby. Okay, well, why don't I wait till I get pregnant, and then I will get some insurance? Okay, that sounds like a good idea. So there's just all kinds of issues that are going to start coming up in here. And so the question is the subsidies. And the problem is that the subsidy issue runs into the budget deficit issue. Okay? And it's really a shame because other countries do this. I mean, every other industrialized country has universal coverage, and which means that they do just a lot of cross subsidies, but they're kind of behind the scenes. Because health insurance is not like normal insurance. Normal insurance, people who are at high risk spend more than people who are at low risk. If you've got a bad driving record, and you're a driver, you pay a high premium. And even if you're statistically likely to, just because you're a young male or something, you had no problems at all, but still you're going to pay more than if you're older or if you're a woman, just because statistically young men are more likely to, right? In health insurance, we don't like that, so we're going to try to charge everybody more or less the same, and that means that the healthy people, the young people, have to pay more than they're going to use, and the sicker people spend less than they're going to use. And that works, it works well so long as no one understands what's going on.
PR problem. I mean, why don't they just do a better job of selling the bigger picture in terms of a concept? It's scaring the hell out of me.
Okay. Well, the President of the United States has been selling the concept vigorously for 4 years now. Okay?
I think everybody understands it. Sorry.
Well, he has been trying. He's the communicator-in-chief, as we call him. And that guy is like the best university professor ever, and he knows how to talk. Okay? He knows how to explain stuff, actually. And I think it's very complicated, so some people are just confused. But I actually think that there's a fair number of people who actually do understand it and who don't want it, actually. I think that's about 50%. Well, that's these people. We've been having 4 years of discussion of the Obamacare now, 4 years nonstop. And half the people, and by the way, over time, the percentage of the population that likes Obamacare declines. Ooh, that's a bummer. Includes Democrats. Okay? So it's a dilemma of a problem. It's a problem of the American people, and I think we can all speculate about this, and no one knows why the Americans are not into kind of like we're all in this together. Let's all join hands, sing Kumbaya, and have universal health insurance. And I personally think it has to do somewhat with our sort of nation of immigrants, and people are very diverse. There's more diversity, and people identify with subpopulations rather than the whole population. I don't know if that's the case. It just is the case that universal health insurance has been tried repeatedly over the past 100 years. We're still not there. Yes?
I wonder if part of what your question was, though, is there will now be an expanded number of people who have health care. So the uninsured services that providers and hospitals were not able to claim are now going to be reimbursed to those provider level. I imagine what you're going to say is that doesn't really change that's not a significant enough portion to fund the system.
Sure, but, there will be less charity care for sure. And that will be good for the hospitals. The ones that really will benefit from this, hopefully, in their view, are like the private health insurance companies, because right now they're paying for the uninsured via the prices for the insured, and this should help them a bit. But it doesn't do anything for the total cost of care. In fact, the total cost of care is going to go up, because if you take people who don't have health insurance and you give them health insurance, the very first thing they do is schedule an appointment at the doctor's office. They're not stupid. All right? What we saw in Massachusetts when they implemented that Massachusetts care was sort of the forerunner of Obamacare, and they implemented quasi-universal coverage, and the very first thing that happened was that the physicians' offices were swamped, absolutely swamped. The people who don't have health insurance use health care less. They do. And it's true that some of it, if you get in early, you can prevent complications and save money down the line. There's a penny-wise, pound-foolish dimension of all of this. But the overall reality is that when people use more primary care, they also use more specialty care. They also use more hospital care. Because the way to get into the hospital is to see a doctor, you know? The way to get, one test leads to the next test, and the second test leads to the procedure. The procedure leads to the follow-up procedure. Okay, that's medicine. Okay.
So, excuse me, charity care. Sure. You touched on that. Can you expand, please? What do you mean by that will go away, or?
Well, in principle,
like free clinics, for example.
Well, in principle, of the 50 million people without insurance in the U.S., they are getting some care. Less than the insured, but they're getting care. That's charity care. Now, if some fraction of them, up to 30 million of them, have insurance, all of their utilization will be non-charity care. They will have some sort of insurance, either Medicaid or a private plan, which will pay the doctor's office, pay the hospital. And so the amount of charity care that the hospitals and doctors give out will go down. There will still be 20 million people without health insurance, and it's a kind of a changing mix of people. And so they will still get care the way they get it right now, which is some combination of safety net hospitals and community clinics. And they access other providers who just kind of write it off. All hospitals do a fair amount of charity care. And some physicians' offices do charity care. Most of the big problem, if you're uninsured, is actually access to physician services more than hospital services. And so you're mostly likely to get your care from either community clinics or physicians who are affiliated with hospitals somehow. Yeah.
Will this affect your subsidy?
Oh, to the hospitals, for example, the safety net? Oh, the government says, it should. Why are we giving you, in fact, part of Obamacare does take away some of the subsidies through Medicare for the hospitals because of this, because they say, look at this, you're going to have less charity care. And the hospitals are like, oh my God, that's our money. That's our money. We have a lot of uses for that money, and we need it. And like I said earlier, a big fight about underlying this whole thing is the hospitals, we're going to be giving them insured patients, and we're going to be taking away a bunch of stuff. And they're like, how do those two things compare? And if you work for a hospital in the financial area, that's your job, is to figure that one out for your hospital, because it's going to vary a lot. How much charity care does your hospital do? That in turn basically depends on where is your hospital physically located. Are you sitting in the middle of a bunch of poor people or neighborhoods? Are you sitting in the middle of a bunch of rich neighborhoods? That's what drives your payer mix mostly, if you're a hospital. So anyway, other topic, other questions?
Sorry. Do you have any idea of the 50 million, how many are at the poverty level and how many are over the, like 400 percentile of the poverty level?
I don't have those numbers in my head. That those numbers are available. I mean, it's pretty easy, the kind of thing they have that. And so they know how much the subsidies, how many people will get at each subsidy level. If that's
I could understand people at the low end of the scale not wanting to pay anything because they haven't been, but people in the middle income range that don't have access to insurance, I would think they'd be excited to be able to get it.
Because health insurance is expensive. The family plan, average family plan in America, how much does an average family health insurance plan cost in America today? Okay, yeah, $15,000 a year. And easily, in some areas, easily above that, in New York or something, way above that. Other areas, it's a lot of money. It's a lot of money. So yes, there's no question that that people, and we can see it in Massachusetts. Of course, Massachusetts is different from America, okay? And Massachusetts is kind of like, you know, it's like all those things. Well, they've got universal coverage and affordable health care in Canada. Why can't we do that in America? You know what the answer to that is? What's the difference between Canada and America? They wait for their hips. Well, we wait for something. No, Canada is full of Canadians. If we had all that, if we had a bunch of Canadians, we'd be there. Which gets me back to my other proposal, that we simply annex Canada and merge with Canada and then allow the Confederate States of America to secede. Okay? Sell Florida to Cuba, Hawaii goes to China. I think we got a plan here. All right? Well, whatever. Okay. Let's talk about the insurance exchanges. Okay. Now, the insurance exchanges, let's be clear. What is a health insurance exchange? The idea is most people who are not getting governmental health insurance in this country get it through their employer. I have health insurance because I work for the University of California, and as a fringe benefit of my job, I get insurance, and the university is very paternalistic. I have a choice. I can choose they have a PPO, a Kaiser, or some other HMO, you know, that kind of stuff, and you all probably have various choices of that kind. And the employer is my advocate and makes it sort of simple for me, gives me 3 choices rather than 3,000 choices, and subsidizes them and kind of standardizes them and does that for me. It sort of simplifies my process. But for people who don't work for large employers like that, it's very confusing and it's very expensive, and a lot of the health insurance products that are out there have like exclusions and stuff that you don't really understand until you get that need. There's all kinds of problems. So the idea is to have an exchange where it'd be like these online exchanges where you could compare apples to apples, different kinds of plans. What are their prices? What do they cover? Sort of standardized. And that is a flat-out Republican idea, right? Because what it does is it allows private health insurance companies to be used for the uninsured and the low income in a way, as opposed to putting these people on public insurance. Okay, and the Obama and the Democrats have embraced this. I think it's a good idea myself. They have embraced this because it's a way of promoting consumer choice in a sort of private health insurance system. Obamacare is an attempt to achieve social goals through private market mechanisms. It's really in its essence. What's the social goals? Universal coverage, that's a social goal. Overall moderation of costs, I guess that's a social goal from a budgetary perspective. And how are we going to do it? Well, we're going to the extent possible, we're going to use private health insurance companies, dealing with private doctors, private hospitals, and even Medicaid, which is a public company, a public entity, contracts out. A lot of their work is done by private health plans. If you're in Medicaid right now in California, you're also probably enrolled in HealthNet or in Blue Cross or in Molina or in something like that nature. And Medicare relies a lot on private plans, Medicare Advantage and other things of that nature. So that's just the American way, is to try to achieve public goals with private means. Okay? And Obamacare is part of that. So the state, you could have had a federal exchange, kind of like the federal employees' health benefits. That was really a model underneath that. The federal employees have that. They have a certain number of choices of health plans. The federal government, Office of Inspector General, make sure it's all clean, standardized, comparable, legal. All the bad actors are out of there. Boom. And that's what members of Congress have. So, but of course, we don't want to do that because that's federal. We don't like federal. So we're going to turf it to the states. And so each state is going to have this insurance exchange. But the states get to decide whether or not they want to do this. The Democrat states say, yeah, I like to do this because then I get all that federal money. All those subsidies are going to come to my state. And then we're Democrats. We like insurance expansion. And we like somebody else to pay for it. That's called the federal government. We're on board. So California is a big leader in this. All the dark blue states are saying yes, and then the Republican states are saying no. This is yet one more governmental intrusion, another mandate that they're going to come, because with these exchanges comes all these rules, of course. And they're giving us subsidies, but then they're going to make us have all these rules, and they're going to, I think that the sort of the worldview of the Republican worldview is that the Democrats want to kind of like corrupt the moral fiber of the people by giving them sort of subsidies, but then forcing them to behave, like that, some sort of carrot and stick thing. And no, we're not going to do that. We're not going for that. So they're not creating these exchanges. They're refusing to do it. And so that is a major headache for the Obama administration, because then they're going to have to go in there. And I just want to see which federal employees drive into Birmingham, Alabama, and say, I'm doing the federal insurance exchange, okay? Or, Cheyenne, Wyoming, these kinds of places, very hostile to government and Obamacare, the face of Obamacare. You want to be the face of Obamacare in Cheyenne, Wyoming? You'd have to pay me more than I'm getting paid now. Let's put it that way. These things are devilishly complex, even in a state like California, which is a very pro-Obamacare, very Democrat, very into this. They're working hard, but there are endless rules for what kind of plans will be able to market themselves through the exchange, how the subsidies are going to be actually administered, and so forth. I think I've got something on here. That was just, I want to just stick with that for just a moment. And there's really two types of insurance exchange philosophies. We'll call them the California model and the Utah model. The Utah model is, and Utah's a leader, by the way, even despite being a Republican state, it's actually a leader in insurance exchanges, because it's a Republican place, and this isn't a Republican idea. And that is to say that we want to enhance consumer choice in markets, and the problem is that consumers are confused, they don't have good information, so it's going to be a marketplace which is going to make it all more transparent. What are the premiums? What are the benefits? And then any health plan product can come in. They just have to say what are their benefits and what are the premiums, and then you go online and you kind of, you decide. It's like Amazon.com for health insurance. In fact, Amazon will probably end up running it. They probably already do the back office. Why not? And you're done. And so that's consumer choice. The California model is, oh, no. That's not good, because what that's going to do is it's going to allow these health plans to kind of like set any product, any benefit design that they want and any price premium that they want and market themselves any way they want. And this is going to start looking like Amazon.com, and we don't like that. What we want to do is make sure that all these health plans have that they have good benefits and comprehensive good benefits, and that the premiums are low, and that there's no discrimination against anybody that's got a pre-existing condition, and that a whole variety of other things. And so what we're going to do is we're not going to be like this passive, any willing health plan. We're going to be an active purchaser. We're going to tell the health plans, you want to come in to the exchange, you've got to do this, 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 and this. You've got to have these benefits. You're going to give you a little bit of choice, but not a lot of choice. And you want to have your premium's got to be within this kind of range, or we're out of here. And you got to, we're going to pre-vet you. And so we, the state, is going to do the heavy lifting, and then the consumer can get to choose. Do you want a sunroof on your car or not? It's that kind of level of choice. What color do you want your car to be painted? But not like, do you want to have a car or a truck or a motorcycle? We're not going to let that kind of level of, and that's definitely the California model. And that's also like the federal employees' health benefits model. The federal employees' benefits are pretty standardized. It's pretty. Okay. So those are just the two different versions. The Utah model is one heck of a lot easier to implement, because you just kind of, and my guess is that a lot of states will end up going that way, because if they don't get an exchange up and running, the subsidies flow through the exchange. And if you say no to federal subsidies, you are violating the first rule of state government, which is get as much money from Washington as you can. Okay? The best kind of money to get from Washington is for like military bases. That's like the best money. But after that, we'll take anything else. All right? And this is real federal dollars coming into your state. And so if you're a governor of a place like Florida and you say, I don't want this federal government money, you're like, the hospitals in Florida are going, tell me again? Tell me again? You're going to, you don't want to take this charity care burden off. We're still going to have to pay those taxes. We're still going to get the Medicare cuts that we're talking about. But now you're not going to take in anything? You're out of your mind, Governor Scott. But these people say, principle. So principles. All right. So that's it. Questions about insurance exchange? Sir.
Wait.
Yes.
Oh, thank you. The New York Times last week predicted that the private insurance policies would have wider and increasingly deductible payments or larger co-pays with the Affordable Health Care Act as a result. So in other words, wellness programs, other incentive programs like Safeway is doing would become very much more prominent in the private sector.
Okay. So the question there was, what will the benefit designs look like that go through the health insurance exchanges? And part of benefit design, there's two aspects of benefit design: what's covered, and then what kind of copay deductible do you, the patient, have to pay for that. And the hard truth of health insurance is there's like three components: how much is covered, what kind of cost sharing do you have, and what's the premium. And if you want to have comprehensive coverage and low cost sharing, you can do that. You have high premium. Oops, don't want that. Subsidies, we don't have enough subsidies for that. So then we got to do, okay, well, if you want low premium and low cost sharing, you have to have thin coverage. Ooh, don't want that. It's written in the law, we have to have 10 essential benefits. We've got to cover everything because everything's relevant to health care. Except for cosmetic surgery, everything's relevant. We don't want that. Okay, well, what about cost sharing? Okay, we don't like that either. Okay, so, the law and policy makers are just a little bit vague on this cost sharing thing, and how much they don't like it, but and they'd love to outlaw it. I mean, they would love to outlaw it, but then they'd love to write a law that said the tide can't come in either. All right, but they want, because the things, everything. But by the way, the rule of healthcare politics is everything that increases healthcare costs is politically popular, and everything that decreases healthcare costs is politically unpopular. Okay, the things that decrease healthcare costs are coverage exclusions, high deductibles, low payments to doctors and hospitals, etc. Okay. So I think that we are, in those exchanges, you are going to see what we call thin benefits, which mostly means high cost sharing. Because most services are going to be covered. They can't, it's very hard to say that we're not going to cover certain services. Because there's very few services that are covered that have no benefit to anyone. Usually most healthcare services have high benefits to some people and low benefits to other people. So you got to cover it. You just try to get it to the people who will benefit and not to the people who won't benefit. And you can't do that through coverage easily. So I do believe that. Yes?
I didn't get the distinction that you made between what you called the California model and the Utah model.
Okay. It's the Utah model, the theory is let the insurance industry offer whatever products they want, but just make sure that they really explain what their products are, what they cost, and what they cover, and all that, and then let the consumers choose whatever they want. If you want to have a health plan that has thin benefits and a low and high cost sharing, but a low premium, that's okay. If you want to have a product that has very comprehensive benefits and a very high premium, and you pay that high premium and you want to do that, that's okay too. If you want to have a product that doesn't cover contraception, that's good. Well, you can have that one. And if you want one that does, we'll have one of those too, etc. And sort of a little bit more of a laissez-faire kind of your choice. Whereas the California model is more like, no, all health plans should cover all things that are valuable, and we want to have the state or whatever bargaining for low prices, and it's kind of like the state and the insurance exchange as the wholesaler, advocate for the consumer. It's going to be us against the insurance companies, and blah blah blah. That kind of that's the gestalt. Now, how it works in practice, it's going to be. But those are a little bit the thing. Yes.
So, excuse me.
Oh.
So, can you explain a little bit about the partnership exchange? How would it be? Is it somewhere in the middle?
That word is not familiar to me. Partnership exchange. Okay, it's in here.
Because,
Okay,
in the timeline, you also have February 15.
Yeah.
The partnership blueprint is due.
There is some states are willing to take on some. The insurance exchanges have multiple functions, and the creation of the exchanges requires the states or somebody to develop a lot of infrastructure. And the question, some states are like gung-ho on doing everything. Some states are saying nothing. And some states are saying we can do some parts and not other parts. And what's one of the tasks facing the Obama administration, the people that are in charge of this, is how to help well, first of all, for states that are saying no state exchange, they're going to have to go in with a federal exchange. That's going to be like a real bummer. And the states that are willing to go in for some of the functions, they're going to, how can we help them out? So technical assistance of various kinds and different types of functions to get them going. Because California is different from many states in the country in that we do have a long history of active purchasers of healthcare, Pacific Business Group on Health, PAC Advantage. There's been a variety. The whole concept of insurance exchange and group purchasing like that is, at least if you're into health policy, if you're wonk, is not a new concept. And so, therefore, it was easy. The head of our health insurance exchange is Peter Lee, who formerly was the head of the Pacific Business Group on Health. He knows this kind of stuff. And so that's great. It's a great resource for us. But if you go to a lot of other states, they just, they've got a health, in most states in America, they've got a health insurance exchange already. You know what it's called? Blue Cross Blue Shield. Right? If you go to Alabama, they've got 90% market share. Okay, that's the way it works. Yes.
When does California enact the
health insurance exchange?
Well,
policy?
enrollment is supposed to begin in, I believe it's October of this year, and the benefits are, people are actually supposed to be getting benefits, et cetera, in insurance January 14. That's the original timeline, and California is hoping to stick with it, and I'm not an expert on that. I'm assuming they're still...
Will this also cover people with pre-existing conditions as well?
Oh, absolutely.
Okay.
Absolutely. Okay, let's move on to Medicaid. Medicaid, the same, is basically the same theme. Medicaid is a federal program administered by the states. So each state has its own Medicaid program. We choose to call ours Medi-Cal, but it's basically California Medicaid, and it's funded jointly by the states and the federal government. The split depends on the average income level of the state. Poor states, all the Republican states, get the majority is funded by the federal government. Rich states, meaning the Democratic states, are paid more by state income, all right? Which is once again one of the great ironies that the states that vote Republican are the poor states that get most of the federal dollars. It's just once again, it's like the state, by the way, with the states with the highest federal payments per capita of all in are Alaska, Wyoming. Okay, the most Republican states in the country. It's just like perfect. Okay, anyway, a whole bunch of states have said, no, we won't accept this. We will not take on the Medicaid expansion. The Medicaid expansion it would take everybody up to 133% of poverty would be covered regardless of anything else. Right now, Medicare eligibility varies all over the map. The core of it is frankly, low-income single mothers and their children. That's like the core of Medicaid, and then certain people with disabilities are in there. But states have a large discretion as to covering just low-income non-parents and other categories. But this would be, regardless of any of that, 133% of federal poverty level. That's what would get you the extra 15 million people to get up to that. All of the expansion would be paid for by the federal government with no contribution needed by the states for the first 3 years. And then after that, the federal government is kind of like, well, you know, go with God, right, as far to the states. And that's what the Republicans don't like. It's another example of getting us, you know, hooked on methadone, you know, and then, you know, sending us out there. And so we won't do it. The problem with that, of course, is like, wait a minute, once again, you're not taking federal money? Are you out of your mind? And so they're wrestling with that. They're wrestling with their conscience. Their conscience says, no. Their political savvy and their hospital industry says, you are out of your mind. Take it. Take the money. And so, anyway, they are, and if you're a big Obamacare person, you can follow, by the way, you can follow all of this stuff in detail. The best sources are the Kaiser Family Foundation, the kff.org. They follow this stuff in detail. And locally for the California side, I would send you to the California Healthcare Foundation's website, chcf.org. They follow this stuff in detail, and they stay up to date, and all of that. They're much better than any other source, in my opinion. Okay. So once again, so let's step back. Obamacare's main target was insuring the uninsured. It targeted 30 million out of the 50 million uninsured. Half of those, 15 million in round numbers, Medicaid, 15 through the health insurance exchange and private health plans with subsidies. A bunch of states are saying no to the Medicaid part, so we ain't going to get that at all. Okay, California's taking it. We want it. Federal money, we'll take it. We want it. We love it. Boom. And then on the exchanges, it's unclear because those states that are not building their state exchanges will get a federal exchange. Assuming that actually gets set up, there is actually some controversy about whether the way the law was written, whether they can even put subsidies through federal exchanges, which is like very mind-boggling. That was just a glitch in the legislation. It would have to be, if it depends on the courts, But if they rule that you can't send it, then the Congress would have to, of course, rewrite the bill. But Congress includes the House of Representatives, which is Republican. They would not do that. Okay, now standing back, so that's kind of like short-term implementation stuff. Then there's like what we might call longer-term implementation issues here. And this cuts down to the whole issue of cost control. Because all of this stuff, I mean, health insurance, expanding health insurance, other things equal, is like you got a fire going, it's called healthcare costs. Health insurance is like taking gasoline and pouring it onto that fire. Okay? The fire burns more. Okay? All of this stuff is cost increasing. It's also providing access to care for people, and that's a good thing, but it's increasing costs. And so how is that gonna jive with the budgetary realities at the federal level and at the state level? And that no one knows. What we do know is that there's no serious talk about anything in Obamacare about dealing with it. They just, they follow the Massachusetts model. The Massachusetts model says, political model says, first expand coverage, then go to cost control. Okay? Because we've tried in the past, first try to deal with cost control, and then once we control cost, expand coverage. Well, we never get the cost, we can't control cost, so we never get the coverage. Okay? So they flipped it. And there's some good arguments in favor of going in that direction. The problem is they're now in the let's control cost phase in Massachusetts, and it is difficult. It is difficult. Okay? And actually, in the short term, what they've really discovered, the best way to do it is get more federal dollars into this state. That is, by the way, the best way of dealing with your state health care problems is dollars from elsewhere. And I'm in favor of that. I'm thinking that if we could get some more money out of Arkansas and Alabama into California to supplement our money from China, that's actually my plan. My plan and the governor's. We're together on that. This shows the mindlessness of the Republican states. These are the estimates up through 2022, they would have to increase spending out of federal dollars, but they would get so much federal money that would come in and decrease their uncompensated care that on net they would benefit enormously. And so you really, I think, honest to God, have to give credit to the Republicans. They stand by their principles. That they will turn down all this corrupting federal dollars and stick with uninsured people. It's better than being on the federal dole. Okay, it's actually, but if you're a hospital in one of those countries, in those states, you're kind of going, I don't believe this. All right. Okay, essential health benefits, and then we're going to wrap this thing up. 5 minutes. Okay, essential health benefits is okay. We got all these plans that are going to go through the insurance exchanges. What are they going to cover? Obama said they got to cover everything that's valuable, that's essential. And that's 10 categories, and that includes ambulatory, hospital, emergency, maternity, mental health, prescription drugs, rehab, lab, etc. Okay, now a lot of existing health plans don't even cover a lot of that stuff. So these plans that are going through the exchange may be more comprehensive than most of the health insurance plans that are out there in the world today, particularly ones that are sold in the small group market. The plans that are sold to large employers like the University of California tend to be very paternalistic. They cover a lot of stuff. It's great. But the plans that are sold to people who work in restaurants and in small businesses tend to have high deductibles, and they exclude a lot of things, and they have a limited number of visits, and et cetera. To save money, to keep the premium down. And so these will be more comprehensive than that. They put limits on overall cost sharing that we call the annual out-of-pocket maximum on that. And so the dilemma on this is, how do you make this affordable? If you have pretty rich benefits and you limit out-of-pocket, and you want to have this to be a low premium plan because the people coming in are low income people, the subsidies are not actually that fabulous. Unless you're really right at the very low end, the subsidies aren't that fabulous. And people are required to buy it under the law, and so you're now saying we're going to require people to spend a bunch of money to buy a product which previously they didn't want to buy. It doesn't sound very good politically. Okay, what are we going to do? No one really knows. One option is that these plans will be very narrow network plans. That means they won't cover a lot of the physicians and hospitals. They will just contract, they will be contract with a subset of the doctors and hospitals that are willing to accept lower rates. And so they will look like Medicaid plans. Medicaid managed care, if you're familiar with the business, are plans, private plans. Some of them are not-for-profit, some of them are for-profit, some of them are provider-sponsored, some of them are Blue Cross kind of plans. And they tend to have restricted numbers of physicians and hospitals in the network because those are the only ones that will accept the low rates that they're willing to pay. And so it's quite possible that these plans going through the insurance exchanges will actually look more like Medicaid plans than they look like the plans that are offered to the University of California or to federal employees or something like that. Now, that's better than nothing for the people who are uninsured. I mean, Medicaid managed care it's got some, the providers aren't too keen on this. They kind of they don't want more Medicaid. Wait a minute, that when the smoke clears, we get more Medicaid. But that is, how are they going to square that circle? They're either going to have narrow network, or they're going to have a high cost sharing, or they're going to have a high subsidy, which means higher taxes. Something in there has got to happen. Okay, and you kind of go, okay, let's watch this. Okay, and so if you're like a real cynic, okay, you say, if I was in Congress, if I was a member of Congress, and I was looking at an absolute federal budget deficit disaster, let's say the Chinese want their money back. Okay, let's say that the Chinese and whoever else has a surplus find someplace else to invest their money than U.S. Treasury bills. Okay, if they stop buying U.S. Treasury bills, the interest rate on the U.S. bond goes up. Right now, it's about 1.5% to 2%, the 10-year U.S. Treasury bill. Okay, what if it goes up to about 6%? You know what happens at 6% on the 10-year bond? You know what happened in Greece, Spain, Portugal, Ireland, and Italy when you hit 6%? The government falls. Okay, because paying the deficit, paying the bonds is before everything. It's before Social Security. It's before military. It's before Medicare. It's before anything. Okay, so we are only sort of doing what we're doing because the world is willing to loan us money at 1.5%. If that interest rate goes up because they find some other place to put their money, we're going to have a serious problem. So if I was a congressman looking to get reelected, I would say, let's look at Obamacare again. Obamacare does two things. It reduces payments to hospitals and stuff like that. It puts some new taxes on drug companies and other people we don't really like. That's all reduces our cost, and then it spends a bunch of money by these Medicaid expansions and these subsidies. What if I don't do that other part and just do this part? Oh, you know what that would do to the federal budget deficit? Very nice things in terms of shrinking it. So we could just delay the whole thing, just push it off, a few more years, that may happen. Okay? So I want to wrap this thing up by saying Obamacare is a very ambitious effort to expand coverage in an era of federal budget deficits and economic sort of turbulence. And the political challenges, in my view, really boil down to that: squaring the circle. How can we achieve the social goal of expanding coverage? We chose to do it in a period of where we didn't have a lot of extra money to spend. In fact, we were supposed to spend less, and now we're trying to spend more. It would have been wonderful to do this in the 1990s when we had these big budget surplus, the Clinton era. It would have actually been easier to sort of swallow. Well, we didn't do it then. We're going to try to do it now. And how that works out is the big challenge facing the president, Congress, and all of us as citizens. So on that point, I want to thank you and turn it right back to Stan.
Thank you. Thank you very much, Professor Rob. Here's another great communicator at our level. So thank you very much for coming. Have a safe trip home.